from Clemson University. And his talk, the title is Developing a Statewide Network for Outbreak Detection, Forecasting, and Coordinated Emergency Response in Medically Underserved Communities.
All right, well, thank you all for having me here. I'm very excited to give this talk. I'm Lior, and my talk probably won't go the entire 45 minutes, so you are more than welcome to interrupt me with your microphone if you have questions throughout. Trying to now manage this mouse and the microphone on two different sides of the, I think I figured it out. I'm a scientist, I can, or use this, look at these devices. All right. Pandemic threats. We've obviously heard about these, throughout our entire lives. Obviously, everybody here experienced going through COVID. But COVID was not an anomaly. I mean, we've heard of the Black Death or the bubonic plague. That was estimated to kill up to a third of the world's population. Obviously, the 1918 influenza pandemic, that killed between 50 and 100 million people. And to just put that in perspective, the world population was about a fifth or a sixth of what it is today. So that would be the equivalent of about 500 million people if that were to have happened today. The HIV and AIDS pandemic, that infected almost 100 million people, estimated to kill between 36 and 51 million. Now, emerging pathogens with high pandemic potential have substantially increased over the last couple decades. As the human population expands out, deforestation occurs, we go into animal habitats, climate change is also shifting patterns. We're just exposed to a lot more zoonotic viruses. So just bringing you back to the 2003 SARS outbreak. A lot of us remember that. It was very scary because it had a pretty high kill rate of almost 10%, but it only infected 8,000 people. SARS-CoV-2 only had about a 1% death rate, but it infected so many people worldwide that it led to well over 1 million deaths in the US alone. There's over 7 million deaths recorded worldwide. And these numbers, by the way, are complete underestimates. I mean, chances are that these numbers are going to be much higher, and some studies are starting to show that. Now, of course, COVID-19 was bad, but you can just imagine there is a new coronavirus strain that has the infectivity rate of SARS-CoV-2 with the kill rate of SARS-CoV with the original SARS. The main reason why SARS was not as infectious as SARS-CoV-2 was because people did not become infectious until they were showing symptoms. So it was much easier to isolate folks before they could spread it to others. There's no, natural selection for that other process that would explain it. It, for all intents and purposes, that is random chance. There is nothing stopping the next coronavirus from having a kill rate of SARS, of the original SARS virus, and being able to infect others before they show symptoms like SARS-CoV-2. So the pandemic threats continue to loom. We do have to be vigilant about not putting it in the back burner just because we went through one, and hopefully we don't have one for a while, but we do have to prepare. This is also why we're so focused on mitigating disease spread. What this slide is essentially showing is if you have a reproductive number of 2.5, and that means that at the beginning, of a pandemic, the infected person will on average infect 2.5 others. That one infection can lead to 244 infections in just 30 days. But if you can reduce exposure by 50%, whether it's through non-pharmaceutical interventions, masking, screening programs, so testing and screening, so you isolate soon after you show symptoms, that one case turns to 4 in a month. If you could get 75% exposure reduction, you can get that down to 0.06, so almost 1 in 20. The other thing we know is that if you can quickly and efficiently allocate resources at the start of an outbreak or pandemic, you're going to save a lot more lives. And we remember throughout the COVID-19 pandemic, there have been a limited supply of essential resources. That first it was ventilators, and then masks, and then testing kits, vaccines, and then treatments. And this poses daunting challenges for public health officials. And it's not just in health systems. and health departments, it's universities, corporations, and other large institutions. So if you can efficiently allocate your resources, you can improve health outcomes. I will give a good example here. At Clemson, at the start of the pandemic, we wanted to do random surveillance testing. I think MUSC was actually providing the tests, but we did not have enough tests to test everybody. Testing resources were limited. We maybe had 500 tests a day. So we could do random surveillance testing, or we could come up with a more targeted strategy. And what we did was we started off with random testing, but if we detected that there was an outbreak in a residence hall, we stopped the random testing and we shifted all of our tests to that residence hall. And what we found was that we were actually twice as likely to detect a positive test that way. And what that effectively does is double your resources. We're not doing anything different. This costs the same amount of money. You know, this is at the end of the day, some coding algorithm to just allocate or just to find out where the outbreak is happening. So what we're going to talk, one of the examples we're going to give today is how can we do the same thing with mobile health clinics? And I'll talk about how effective those were in distributing vaccines at the beginning of the COVID-19 pandemic, especially in areas that did not have those vaccine distribution centers. So if you can allocate them to the areas where, to the populations that are at highest risk and also don't have access to it, you're going to save a lot more lives that way, depending on the order you do that in and who you are targeting. So let's go back to data analytics and forecasting, why it matters. So we talked about, early detection and prevention. You're going to identify emerging trends and ultimately proactive interventions to mitigate disease spread, inform public health policies and targeted policies. So when we think about the economic impact of COVID-19, it costs the world, trillions of dollars. I know a lot of us went through certain stay-at-home orders or closure of non-essential businesses. I remember my mother-in-law was in Pennsylvania, and they had a policy where if there was a COVID case, they closed down all the businesses in their county, and that upset a lot of people because they said, well, it's not happening in my neighborhood. Why do we have to close down? You can imagine if that you could get more localized rather than doing the county level, you can maybe go to the zip code or census tract level. You could potentially be a lot more effective with these interventions. And that's always the balance, right? You're trying to balance medical well-being with, let's just say physical and mental health well-being, right? That's always the trade-off with these interventions, and we can better optimize it that way. So we talked about the mitigated economic impact, talked about resource optimization, and then targeted interventions, for example, mobile health clinics. So our mission here is to develop a statewide network for outbreak detection, forecasting, and coordinating emergency response. We were recently awarded about $20 million over the next 5 years from the CDC's new Center for Forecasting and Outbreak Analytics. Knock on wood, they'll continue to fund us next year. This is a partnership with MUSC, University of South Carolina, and Prisma Health. Of course, I'm from Clemson, so we're the prime site here, but we work very closely with these, and all these institutions have very big roles. Actually, one of the key players on our team here, Carolina, I'm going to call her out. She is one of our biostatisticians on the project and helping us identify outbreaks via MUSC electronic health records. So, we're really trying to bring everybody together, and I'll talk about that in a sec. DMA Prime, that's the acronym for our title. Disease modeling and analytics to inform outbreak preparedness, response, intervention, mitigation, and elimination in South Carolina. You can see we have a lot of institutions here. I just listed the main institutions. We're one of 13 funded centers from the CDC Center for Forecasting and Outbreak Analytics. And just to talk about quickly how it's structured, there are 3 types of centers. There are the innovators, which are developing the new methodologies. There's the integrators, which are pilot testing them in practice. And then there's the implementers, which are scaling up the successful approaches nationwide. Of course, the way funding works, they were all funded at once. So we have to figure out how to make that work. So DMA Prime is actually a center for integration, but we're really trying to get in the business of local level outbreak detection and forecasting methodology that does not exist there. So we are innovating in that field as well and scaling this up throughout South Carolina. So we're really doing all 3. I'll briefly talk about how this works. So first, it all comes down to data. you could have the best, most sophisticated model in the world, but if you don't have quality data being input into that model, it can only be so effective. So we work with electronic health records from our two largest health systems, MUSC and Prisma Health, digital trace data right now, Twitter, X, and Google Trends. We are doing wastewater sampling statewide. I'm not going to talk about human and animal samples today. We haven't really integrated that yet. And then community characteristics. What is the demographic, socioeconomic makeup of that community? That's going to be very important as we're trying to model and allocate resources. So first, we have our data processing and analytics. We then do outbreak detection, throw this into various infectious disease modeling frameworks, put this in our software for forecasting and decision support, and ultimately help coordinate and emergency response, and including identifying the areas of greatest need. So what is Center for Forecasting and Outbreak Analytics doing in the business of coordinating emergency response? Well, we do know that healthcare in the US is extremely fragmented, and that really hinders emergency response coordination. Even in South Carolina, we have a lot of great health institutions, but there is a lot of them. We have our Department of Public Health that was just recently split. So you have your environmental control piece, you have the drug, alcohol, and other substances. We have mental health. We have the emergency management division, not to mention our two large health systems that are obviously, serve a lot of people, right? So in an emergency situation, if you don't know who is doing what ahead of time and who to reach out to, that's really going to hinder your response. Our idea is that if we can get everybody to use our software to coordinate, we will know who the players are. We will be able to reach out and ideally have them talk to each other through the software and say, this is what we're doing. So just to give a brief example, Prisma Health operated a wonderful mobile health clinic operation to get COVID-19 vaccines out during the pandemic. But it would happen on occasion that Prisma Health would park their mobile health clinic right next to that of their, on the same block as one from the state health department. And, that's really a shame because those are a couple hundred people who would have missed out on a potential vaccine, right? And that's not an isolated incident. And it's not just public health, right? We see this in charities all the time after a natural disaster. All the charities, they're doing this amazing work, but because there's not a lot of coordination. Sometimes there is, but a lot of resources tend to maybe go to just one area, because everyone knows who the high risk areas are and where it's needed, but the distribution isn't necessarily as optimal as it could be. So these are the implementation partners. Prisma Health serves, I think now it's like 1.5 million patients annually. They also have a fleet of mobile health clinics. And MUSC, I know, also has mobile health clinics, serves over 1 million people. Between Prisma and MUSC, I think geographically we cover about 2/3 of the state, close to half the population. That is actually a major benefit for South Carolina that, typically I'm going out on a limb here, but, typically you want, more competition, more health, and that's great. For whatever reason in healthcare, it doesn't seem like that works. And it's nice that we have these health systems that can work together, but we aren't having these territorial battles that ultimately can sometimes inhibit patient care. So there's a lot more coordination there. Clemson Rural Health has served over 10,000 patients annually. They also have a fleet of mobile health clinics. The Center for Rural and Primary Healthcare at South Carolina is assisting with coordination of health services. And obviously our Department of Public Health, they're the public health authority for South Carolina, and we are working closely with them on many projects and implementing this. And along with our community partners, at some point, we want to make publicly available versions of our software to not only inform people of potential outbreaks and what the risk is, but where to find essential resources as well. All of our partners are going to embed our toolkit into their workflows for decision support. So these are just the various institutions and cores. So this is a big center. So we have our biostat and epi core, EHR core, modeling, wastewater, GIS, evaluation, software and data visualization, community and intervention design core, and our public health response core. I'm not going to go into these individually today, but based on the slides I'm going to present, you can probably tell which cores these are actually coming from. And you can see this is really participation all across South Carolina. It's not just one institution carrying the load. So I was talking about mobile health clinics, and I just wanted to give that example. So in 2021, Prisma Health administered over 12,000 vaccine doses to over 8,500 people in 150 medically underserved communities. It was the population, 70% non-white, and 44% of individuals uninsured and 20% on Medicare or Medicaid. So these mobile health clinics really do a good job of reaching medically underserved populations. Clemson Rural Health also provided testing to 11,000 individuals from underserved communities. And what we're going to do, because we talked about pilot testing, is we're going to use our software to identify and prioritize high-risk communities and deliver infectious disease screening to strategic hotspots for outbreak containment in underserved communities. So that's going to be in partnership with our mobile health clinic teams at Clemson and Prisma Health, along with the Ready Lab at Clemson and Remedy, which is a data integration biosecurity company based out in Greenville. We will also be delivering influenza vaccines depending on availability as well. So this is our basic data collection strategy. We have our health system data from Prisma Health and MUSC. It covers about half the population. Wastewater sampling, we're doing the primary data source from wastewater is going to be our 6th largest wastewater treatment plants in the state, covers about 30% of the population. We're also doing additional strategic sampling in the city of Columbia, and then we're doing some H5N1 screening in the wastewater for in some of our dairy farms and cattle farms. Happy to report we haven't found anything yet. So hopefully it stays that way. So we talked about social media data, Twitter, and then Google Trends. And we have our statewide data for infectious diseases. So the Office of Revenue and Fiscal Affairs has all the claims data. We're also getting data for vital records, immunizations, and just infectious disease incidents. But the problem is that a lot of these data are lagged by the time the health department gets it, and depending on the data source, by the time we get it as well. So it's not as useful for real-time forecasting. So what you're actually seeing here, this is all COVID-19 hospitalizations in South Carolina in 2023. Ideally, we would have had all this in real time, but the Office of Revenue and Fiscal Affairs, this is coming from claims data. They don't even get it for 6 months. So what data can we get in real time? Well, it's the health system data. So this is the same outcome, 2023 COVID-19 hospitalizations. And we see Prisma Health in purple and MUSC in blue. We haven't figured out what the hybrid looks like where there's overlap. But really the areas that are giving us the most data are going to be those darker shaded regions. When we're talking about forecasting, you do need quality data. A few observations here or there are not going to do you much good with time series data. So we also supplement this with wastewater testing and then digital trace data, whether that's Twitter posts, whether that's Google Trends. And then the idea is we use AI and really deep learning models to forecast statewide hospitalizations from these sparse data sources, and then use other methods, including census data and community characteristics, into other types of machine learning models to forecast hospitalizations and other infectious disease outcomes in areas where we don't have data. I'll show some modeling results in a little bit. I promise I won't go into detail. The truth is I don't understand a single thing about machine learning and how it works. It is a black box, and we have a great team of folks who know what they're doing. And again, this is the goal. This is ideally what part of our software would look like, is you can put the supplies you have, maybe it's mobile units, the vaccine supply per unit, treatment supply, testing, PPE. And what the software can do is identify which zip code you can go to based on the greatest predicted hospitalization reduction. This is just one example that I use as a demonstration. There's many places we can go with that, and there's many interventions besides just mobile health clinics. Another project we're working on with the state health department is developing targeted communication strategies to combat vaccine misinformation and vaccine hesitancy. So we can use social media data, and we can use that information to first link it to see, is this actually correlated with lower vaccine rates, and then come up with targeted messaging campaigns to just get the right information out there. Obviously, it's an individual choice, but we just want to make sure we're doing our due diligence and folks have the right information. So this is our conceptual framework here, right? We want to show, first take effective interventions, and then we want to deliver them to places where there's a demand and a need for them, right? So this is trying to show this is a data desert. There is no hospital here. There is no additional access to care, right? At the same time, we also want to show, be able to find out, well, where are the actual high-risk regions? Because really, if you're talking about limited resources, you want to find here the high-risk region, and also where there's not additional resources there. Sometimes the highest risk region, and we find that out, that could be the city of Greenville or Richland, Columbia, the city of Columbia. But the difference is there's already a lot of resources there. So if we go and park a mobile health clinic there, even though there's obviously a need for additional healthcare, we're not going to serve that many people because they may have somewhere else to go. That's obviously not always the case. I'm just using that as an example. You want to, when we send out the mobile health clinic there, we want to make sure as many people as possible come out, and ideally as many high-risk people as possible come out. And that's a challenge sometimes, even now. So we're not at the point anymore where we send out a mobile health clinic and hundreds of people show up to get a COVID-19 vaccine. Right now, Clemson Rural Health is doing it for HCV screening. Sometimes we get 20 people who show up, sometimes we get none, right? So the more you can optimize that and choose your locations and put in the prep work, which they obviously do a great job of, the more patients you're going to be able to serve. And the idea is we're integrating this into software to deliver these effective interventions to healthcare deserts that are at high risk. I'll show a demonstration of the software in a little bit. I'll just talk about some of the work we're doing. So we are doing real-time estimation of vaccine effectiveness by variant. We're doing this with Prisma Health data, and we're also going to be doing it with MUSC data. So just going through the boosters that we have, we have the unvaccinated population, everyone remembers the 2-dose mRNA series, or J&J if you got that. Then we had several rounds of boosters. There was also the fall 2024 boosters. Unfortunately, uptake was not very high, so that complicated doing meaningful analyses for their effectiveness. And obviously, we remember the different variants. I don't even remember them, but we remember Delta, we remember Omicron, and then all the Omicron subvariants. So what you see here is that originally the 2-dose mRNA vaccine was very strong, and that was against Delta, but then with waning immunity, it dropped, right? So when Omicron came, it wasn't nearly as effective, but the booster did a good job of bringing protection back up. Here we're looking at protection against emergency department visits. But then the next variant of Omicron came along, and that original booster lost its effectiveness, and then lost it even more with the next variant. But then the bivalent booster vaccine increased protection again. That protection dropped with the next variant. The fall 2023 booster increased protection, and then that dropped with the most recent COVID wave that we had. And I am sure if you have enough data for the fall 2024 booster, you would have seen an increase in protection there. So, especially if you are at high risk, we do know that the COVID-19 boosters do offer protection against hospitalization. So we talked about identifying effective interventions, but we also want to know where they will be most used. So one of the studies we looked at was looking at utilization for COVID-19 mobile vaccine clinics. And we're looking at this from when they launched in February 2021 through the end of March. Why that period? Well, resources were very limited. You couldn't just go to your pharmacy and get one, or your primary care doctor. And really what we see here is, yes, there's some of the darker regions is where we would have seen the greatest uptake, and lighter green, maybe less, but still pretty much anywhere you send it to, you're going to have at least 100 people show up. So at the beginning of the pandemic, you could really do this based on where the need is. But after starting in April, when vaccines were more widely available, demand substantially decreased. We don't have any more of the darker green regions, but this is actually a spot where you see where demand is going to be much higher in some of these greener regions. So there is certainly a utility to trying to incorporate that information. And again, we're not making these decisions just based on the model. It's a decision support tool. There's a lot that goes into deciding where you're sending a mobile health clinic. You first have to have community partners there to spread awareness, to make sure people are actually coming out. Obviously you have to figure out where to park it as well, have those agreements in place. So we showed this slide earlier where you're trying to forecast outbreaks through sparse data sources. This is looking at COVID-19 nowcasting, right? So this is just based on Prisma Health data, but we have these partially observed hospitalizations here, and we're using these random forest and CART models to predict how many hospitalizations we have that week in each zip code. And, the models are fairly accurate. The average accuracy per zip code is close to 70% for this type of model. Not great, but much better than what currently exists. So some of our other models can get it up to 85%. This is a deep learning model that was developed by one of our data scientists. What you're just seeing here is county level case and death predictions using social media data and other community characteristics. This was done through convolutional neural networks and transformers. Again, I have no idea what these are. I'm sure our previous speaker can answer any questions about those. So earlier we were looking at cases, now we're looking at deaths, and the models were fairly accurate. Median accuracy ranged from about 85%, looking at 1 week out. Obviously, once you go further out to 5 weeks, it dropped to about 55%. We're still working on getting the timing of the peak right. What we did find, though, is that symptom reporting via Twitter or X actually increased nowcasting accuracy between 60 to 32%. So if we incorporate that in the model, we actually do get a good boost in the short run. And this is just looking at cases. So between 1 to 7 days ahead, we can see if we compare the blue bar to the orange bar, we do see a notable difference. This is just averaging this out across the course of a week. But as we're getting down to 5 weeks ahead, we're not seeing much of a difference. Of course, if we're predicting the peak, we do see a little bit of a benefit. But if you want to know what's going on now, it's beneficial to incorporate social media data. And in fact, we discovered this after the fact and only recently. Google Trends, pretty amazing. If you type in influenza into Google Trends, even for the state of South Carolina, map that out against the curve against what you see for flu cases or hospitalizations or death, it is almost it doesn't go as high, but the shape of the curve is exactly the same. It'll tell you exactly what flu season was and when it peaked. So this data can be very valuable. I'm going to try to explain here what is going on with these deep learning models that I showed before. If everyone can focus first on the purple line, and what you're seeing in that purple line is those are statewide hospitalizations, but that data ended in 2023. So we can't use that for real-time forecasting. We don't have that data. What we do have in the blue line are electronic health records, along with social media data and other contextual information. And what we are doing is training the models to forecast these statewide hospitalizations based on the electronic health records and other data sources. So what you see in the dashed orange line, that is the training period. And then we run out of data. So now we don't actually know what the truth was. But in 2024, we estimate that this was the COVID wave that's given by the orange line here. And our last data poll, the dates are a little fuzzy, but it was September 16th. And we estimated that on September 16th in the previous week, there were 39 hospitalizations for the zip code in Lexington. And these are the 5-week forecasts. So we're seeing that if we're going about 1 week ahead, we had about 80% accuracy down to about 65% for 5 weeks ahead. The only thing that we hadn't been getting right was the peak in terms of when the most cases occurred. That's important for hospital planning, making sure your resources are there. We have been able to get it down in more recent models from 2 to 3 weeks to under 1 week. Now, it's important to note that this is from a zip code that actually has electronic health records. Not all zip codes have it, as we can see here. So this is another zip code. zip in Colleton County, 29474. So we're using other imputation methods to guess what actually happened in that zip code. So we can see accuracy dropped if you don't have sufficient data, substantially drops from 85% to 65%. But it is still informative, and again, a lot better than having absolutely no idea, which is 0% accuracy there. So I'm actually going to give about a 2-minute demonstration of our toolkit. I pre-recorded this, so I'm just going to sit back with all of you and hope there's no bugs in this. So I'm just going to spend the last couple minutes talking about extensions to additional health domains. We know that in non-pandemic settings, heart disease, diabetes, cancer, and drug overdoses are among the leading causes of deaths and medical expenditures, especially in South Carolina. These are also the same individuals who are at high risk of experiencing severe health outcomes during infectious disease outbreaks. So we're simultaneously working to expand our infrastructure to support health agencies in responding to these other pressing health conditions. And that makes sense, right? If we really want to improve pandemic preparedness and response, one of the ways we need to do that is to reduce the size of the susceptible population by treating chronic conditions today. So it really is all related, and it gives us an opportunity to test some of our methods and make sure they're working in non-emergency settings so we don't have to wait for the emergency to see how well this actually works. This is looking at HCV screenings through mobile health clinics led by Clemson Rural Health. This is just looking at the number per site location. And as we can see, substantially varies. Sometimes you can get up to 140, sometimes you can get 0. We need to do better about thinking about how we send these to the different regions. And that doesn't mean if we expect low uptake, we abandon that region. What that means is that maybe for now, we revisit that one later, but then we simultaneously work to ensure that people know about our services and build that trust in that community so that they come out. Another paper we looked at, in another study, we were predicting opioid, HCV, and HIV hospitalizations in South Carolina. So this is the prediction of all three. The models perform fairly well, but again, it's not just about identifying where the high-risk regions are. This is just zooming in on the upstate Midlands. And what you're seeing here is it's mapping the high-risk regions. We only pulled out the high-risk regions and ignored everything else. Areas with high SVI, that's the social vulnerability index, and high uninsurance rate. So that's given by the black and red lines. And are there other healthcare facilities there that could potentially treat it? So the idea would be we would find a zip code or a region that doesn't have a lot of these resources. So you can see there are some, 29203, that's the one that's always used in South Carolina because it has the, some of the worst health outcomes in the state. And there's other pockets in here as well. So 29611. So we really have to do both. And, these models are a lot easier because these conditions are not seasonal. A lot easier to predict. So even 1 year out, we can, I think in this paper, using data from 2021, we could predict the number of hospitalizations in each zip code in 2023 with 82% accuracy. And that's, again, there's not a ton of shift in month to month, or well, I should say in year to year. So our next steps for our center is we want to incorporate the wastewater testing into our forecasting framework. That is just a little more complicated logistically because those are what are known as spatiotemporally sparse data. We don't collect the wastewater data everywhere, and we don't do it all the time, and models do not like that. They like everything, as anyone who's run a data analysis, they like everything to be in one row. They don't like missing data. So we're working on that. We're also we're working now with Clemson Rural Health to start tracking the proposed locations for future healthcare delivery to improve public health response and coordination. Obviously, Prisma Health, MUSC, we're all involved in this, not to mention our state health department, who's really been an amazing partner. And the idea is to start providing real-time summary measures and utilization statistics. So when we do something, that feedback is typically stored internally. Maybe it's collected by a nurse practitioner or someone out in the field, and it's an Excel file. Not everybody necessarily views it. It's a little bit harder to use that in decision-making when it's stored in a file somewhere. We want to integrate all that into our software. The other thing we're working on is incorporating GIS analysis to maximize healthcare utilization. There's some really cool work we're doing. I didn't show it today, where you can actually pick different locations on a map and see, based on the census block, where and based on minimal driving distance and walking distance, where the most amount of people are likely to come out. And then we want to be pilot testing this software in real world settings. And we're actually launching our first pilot test in November with Clemson Rural Health to deliver infectious disease screening to a high-risk community we recently identified. So thank you, everybody. If you want to know more about our Center for Public Health Modeling and Response, which oversees this, that's the QR code, or you can email me. I'm always happy to have a conversation and collaborate. Thank you.
Any questions?
Hi, that was a great talk. Thank you. The bird flu, which was the cause of the 1918 epidemic, I think that it's in over 500 herds now in the U.S., at least, and they pool milk. Are you guys looking at them? I know the milk is pasteurized, so.
Yeah, so I do believe the state veterinarian and that team is screening milk samples for bird flu.
But none yet in the.
As far as I know, nothing has showed up yet.
Interesting.
At least in South Carolina. Yeah. Yeah, so I heard whether I'm collaborating with rural health centers. Yeah, so right now we are really just expanding our partnerships, and those were the ones that I listed earlier, especially on the public health response side. We do want to bring in more people into our network. As we know, unfortunately, we don't have an integrated emergency. We have people who do amazing things, but it's fragmented. Again, we have our healthcare systems, we have our health departments, we have our other smaller healthcare systems like Clemson Rural Health. We do certainly want to work with community partners, other institutions, anyone who wants to be on board and collaborate. We want that because it really, as the saying goes, takes a village. There's a lot of ground to cover. And in an ideal world, we wouldn't have to identify and prioritize high-risk communities. We could just serve everybody. That's just a limitation of our health response right now. So the more people we can get, the better off we'll be able to actually do this.
Can I just ask people to introduce themselves and where they are? Hello, it's Kate. when you ask your question. Thanks.
So I'm Nate. I'm from MUSC. Really interesting talk. I mean, I assume this model, this framework you guys have developed, it's applicable to anything. And so you could do the exact same thing for cancer, for kidney disease, for potentially outbreaks of asthma, anything. And so I assume you guys are working.
So that is in the next phase of what we are trying to do. So again, assuming additional funding comes through and we can continue the work, we certainly want to expand it to these conditions. Again, they directly inform the health outcomes we're going to see from infectious diseases, but these are also conditions when they're out there, we want to be able to treat them. We want to be or screen for them and treat them. So absolutely, and you're right. With this framework, we could very easily do this. I mean, MUSC has a phenomenal research data warehouse where the EPIC data records are automatically pulled. We have amazing EPIC report writers on the team. Once you set up this system, it is very easy to pull in that data and come up with these models. And it would certainly be a missed opportunity if we didn't pursue that.
I had a question. I'm from MUSC as well. I had a question about the state hospital data. I'm not familiar with that. So is that something that you would get later, or why did it stop?
Provided by the Office of Revenue and Fiscal Affairs, and they actually have they do a really wonderful job. They figured out their mechanism to share data with researchers. They get their data based on insurance claims,
Okay.
but it is lagged. By the time they get it, it's about 6 months.
Okay.
Hi, I'm Jared. I'm from MUSC, and my question is about like data housing and compute power. I imagine that it's pretty intensive running these models and things. So I was just curious if you were kind of pulling in data live or if y'all were housing it locally.
Yeah, it's a good question. Right now, the goal is to get to weekly data pulls and to automate a lot of this. So we're in the process of purchasing a big server. Automation is a very big thing for us right now. The way it works is we ask our EPIC report writers at MUSC and Prisma to generate the data. They send it to our PHR protected box folders. And then our data analysts, including Carolina, who has probably a dozen times already how to create new data sets, and a dozen is an understatement, it's been well more than that, has to transfer that over to our modelers, who then run the data, generate the Excel file, and then give it to our data visualization team to incorporate that into the software. We are working on making this one automatic pipeline, so as soon as our EPIC report writers upload the data, which should also be automated because they have their scripts, it just integrates into the toolkit, and we don't have to do anything unless we want to change the actual protocols.
Yeah. Hey, Dave Lauder, MUSC Pop Health. Have you started to look at non-specific symptoms in outpatient care areas?
No, we haven't done that yet. Right now, we're primarily focused on just predicting hospitalizations for these diseases. And we do a little bit of work in evaluating treatment effectiveness or vaccine effectiveness, but we have not gotten into evaluating symptoms yet.
Yeah, because the start of your talk was underserved areas, but if we're focusing this on where hospitals are, we're probably missing the truly underserved areas.
Yeah, and that is a very, very good question. And we saw this in some of our other research that depending on what you're going to the hospital for, are you going there because you're just kind of receiving your standard care or standard treatment, or are you going there because it's really an emergency or you need care? So hospitalizations are not always the best measure in a community of what the actual health outcomes are there. So in the next extension of our models, we are also going to start incorporating vital records and other information to get a better picture of what is going on. It's a really great point.
I think we have time for maybe two more questions.
Hi, I'm I have a question about the social media that you bring into the model. So you said this increased it by like 16 to 32%. How much weight are you placing on this social media, and then in comparison to the other variables, and why are you choosing this? Because it seems like not everyone is going to go comment about what their symptoms are.
Yeah, that is a great point. In terms of how the model is weighting them, I honestly have no idea. That is, I think, in these deep learning models, some of them, they figure out the weight and how it's like a black box of how it relates to the actual outcome. In terms of, to your question, you're absolutely right. Not everybody reports it. It's just, and I'm just going back to the slide here. We can even see, based on the orange kind of dots, like these are where our Twitter posts are. They can vary from 1 to 6 in a region, or 0 for that matter, up to 25,000. But it's clearly not everybody. It's just additional information to help fill in the data gap. Same thing with Google Trends data. So if you were to base your models only on social media data, I don't think they would perform very well. They just help fill in some of the gaps.
I'm Paul Heider from MUSC, for the folks who can't see. So the other use cases we talked about, both COVID and cancer and all of these, have a continuous rate, right? There is, even when it's a low rate, we still have some of it around. But the bird flu and food poisoning, which would be other things that we could use for monitoring, will this allow us to monitor for those 0 events that suddenly spike up, right? Or
Well, so that's a good question by what we mean by this. So yes, our wastewater screening should be able to detect it if it's there and we're actually doing it. In terms of detecting a really rare event, until it blows up, that's going to be harder to do, let's say, just from electronic health records. If you wanted to do it through electronic health records, one of the strategies we're working on now is taking these panel tests that can test for 20 different diseases. If all of a sudden we see an influx of those coming negative for 20 different diseases, but patients are showing up to the hospital, that may mean that something else is coming up. In terms of the actual forecasting that we're doing and where that's going to go, it is very hard for pathogens that, at the end of the day, that there's just not a lot of data for, because they're not too widespread. But we do hope, part of what we're doing is, yes, we are forecasting where diseases are going. And the other side of that is trying to do outbreak detection for when they pop up. We obviously can't cover everywhere, but we try to get it as early as possible.
We need to move on, but these discussion questions are so interesting and inspiring.